Good evening. Thank you for joining us this evening for this important presentation and training. First, I want to give a land acknowledgement. We begin by acknowledging that we gather on the traditional unceded territories of the Lekwungen peoples, and we acknowledge with respect the nations of the Songhees, Esquimalt, and Wasanich Nation peoples, whose relationships with these lands continue to this day. Before I hand over this presentation to our trainers, I just want to go over a few things. One is that we are recording this session, and if you do not want to be in the recording session, please either move back after 4 rows so that you will not be seen, or, oops, sorry?
Sorry, I just realized I should move back.
Is that okay? All right, or at least face towards the front, away from the camera. And we will not have the recording during the practice sessions for individuals, okay? Also wanted to let you know that bathrooms are beyond this section and accessed from the other side, or there are 3 bathrooms in there, and there are 2 in the hall as you leave the sanctuary, and it'll be on the left-hand side. Our Social Justice Committee is what is sponsoring this program tonight. That includes mostly, of course, Church of the Cross, but we also have a few committee members from Grace Lutheran Church. We introduced a 3-week information session last fall on the toxic drug use crisis, and some of the different agencies told us about how it was like for them working in those fields. Grace Lutheran Church is located on the periphery of the downtown area, and we often get night campers at our front and back doors. Of course, this doesn't affect as much the Lutheran Church of the Cross or St. Luke's for that matter, but it's still an important thing that we should have that's valuable. Look what happened to that poor woman, young woman, who was at UVic. Well, there were lots of people, but no naloxone, and the help that came too late, or was able to give the naloxone too late for that person to live. And because we at Grace Lutheran see a lot of the homeless people and some people who are taking drugs and so on, we saw the grief after a young woman died in our property at Grace Lutheran about 3 years ago. And since then, we've been wanting to try to make more of us able to help if we could, or provide more people with the skills, or have the naloxone on site, or inside, as well as perhaps outside. For our timing, we're hoping to have the presentation and question period until about 7:50, and then we'll have a short break with fruit and scones and brownies and instant coffee and tea. Please forgive us. And then at 8 o'clock, we'll have the trainers do the demonstration, and they will then do individual training. We'll have about 4 people per table at a time. And we are so fortunate to have these trainers with us today. Tracy Thompson is a harm reduction coordinator in Highland Health's Addiction Medicine and Substance Use Program. Candace Morris is a clinical nurse educator in Highland Health's Mental Health and Substance Use Program. They created and developed this training program on their own time and are also presenting this training on their own time. So I now turn it over to Tracy and Candace. Thank you.
Thanks, Barb. All right, when I think I've done so many trainings, it's working? Okay, this is new to me. All right. Fulfilling my childhood fantasy of being on stage. All right. Welcome, everyone. Candace and I are going to give you a bit of an overview of Naloxone and how to use it. And Barb, you already did a beautiful job of doing a territory acknowledgement, and we always build one in as well. And so much gratitude for that. And I think just to say a bit more about the work I do and Candace does, and how this actually disproportionately impacts Indigenous folks. And when I think about Truth and Reconciliation Day that happened yesterday, really it's the ongoing colonization that continues to put people at great risk. So if you kind of looked at the stats that the coroner puts out and you take a look at the Indigenous stats, they look a little different. Usually we see more women being impacted, a lot more women, Indigenous women. So usually it's 60-40 when you look at the general population, and it's closer to 50-50 when you look at Indigenous communities. So I just want to kind of center that in the conversation that we're having, and I imagine that was for Truth and Reconciliation Day, the orange sash. So just important to keep that in our minds as we move forward. So we will talk a little bit about the numbers and provide stats. And one thing I just kind of want to keep in mind is that we want to really kind of focus on our community. When we talk about stats, those represent people, people that were loved and supported in their community. And this is actually a picture that was taken back before the public health emergency in 2016. So we were already seeing impacts in our community. So that's a local picture. And this is just a way for us to try and connect our heads and our hearts around this issue and come from a place of curiosity and compassion. Because when we have conversations about substance use and sometimes the intersectionality of poverty and homelessness, we might have some judgments that come up. So it's really good to come from a place of curiosity. Yes? Mm-hmm.
So this is something that, this crisis is something that fills his thoughts and his mind and his work every single day.
A lot, yeah.
So I'm really grateful.
Thank you, and thank you for your partner who's doing that work. And the other thing I just want to say, like we've got an example of how this, it maybe impact the work we do. It might impact us personally. We might know someone in our personal life that's had a toxic drug event or maybe even died from one. And you yourself might have a remote history of substance use, and you might have a current one. So this is really about how we support and care for our community and move away from that binary of us versus them. And so here's just a snapshot of where we are in terms of British Columbia and the public health emergency. So I mentioned that the declaration happened in 2016, and you can see how it started to even increase in 2015. And so that public health emergency was declared provincially by our provincial medical health officer at the time, Dr. Perry Kendall. And in 2019, you got to see a decrease happening. So some impacts were happening in the community that started to see a trend downward. Does anybody want to guess why that might be? Yeah. So we began to see the expansion of harm reduction programs. Yeah, so we began to see expansion of overdose prevention services. And so because we had a ministerial order that went along with our public health emergency, we opened up overdose prevention sites that didn't have to go through a very long and expensive federal exemption process. So these got to be open much more quickly. We got to see the expansion of opioid agonist treatment, so alternatives for people. And all sorts of reasons. This has been studied by the BC CDC. So there's not one reason why we see this. This is a complex issue, so multiple factors. And it might even be the drug supply. So there might have been a shift in what was maybe potentially less toxic. And then what happened in 2020? Yeah. So we had 2 public health emergencies happening at the same time. And COVID, we all know what the messaging was, small group, stay away. I'm sure the church was doing virtual presentations and inviting people to a congregation. And then we had the other public health emergency, the toxic drug crisis, where that messaging was absolutely opposite, to be together, to be staggering your use with other people, not using alone. So very conflictual. And then I mentioned in the opening just about the impact on Indigenous communities. And you can't really see that, but it says 3.4%. That's the, this is from First Nations Health Authority, that's the Indigenous population of BC. And 17.8% is the rate of death for people that are Indigenous. That's that much more greater than our general population. And that 11.7 times is how Indigenous women are impacted compared to the general population for women. So that is that's quite startling numbers. Okay, I'm going to just see if I can adjust this a little. So the blue title there focuses on the BC Centre of Disease Control. So they have 3 harm reduction programs. They have the take-home naloxone program, which we're going to talk about today. They have a facilities overdose response box, which your partner might be familiar with. It's like a grab and go. It's like a fishing tackle box that you can grab and then respond to toxic drug events that might be happening. And then they offer harm reduction supplies. So sites can become registered and then actually order harm reduction supplies to make sure that people are getting unused supplies every time that they're using substances. So we've seen a dramatic decrease in the transmission of bloodborne illnesses since the inception of the harm reduction supply distribution program. Take-home naloxone actually started in 2012, and at that time you actually needed a physician's order, and so things began to shift, and we no longer need a physician to give us an order. This is available throughout BC in pharmacies, at social serving agencies. Yeah, so we'll train you on how to use it, and then you're done. This is a public health emergency, so we don't have to go through like a credentialing process at all. But I'll say for the take-home naloxone sites that get registered, they get supported by their local harm reduction coordinators. I'm one of them. There's 4 of us on the island. They get supported in us training them to be able to provide the training. Okay, so take-home naloxone, really the goal is to make sure that we get kits into the hands of the general public. It's not for occupational health purposes. So if people are actually at work, so for Island Health, we access naloxone from our outreach teams in a different way. We go through like a provincial product distribution center. We don't draw on the take-home naloxone program because we want that to be going out to people that are going to be witnessing those toxic drug events in the community. So as you can see, anyone can be trained, and kits are free, and there's no cost. And then the kit contents, that gives you a little bit of a visual. So in here, you will have a bottle of naloxone, like 3 ampules in a pill bottle. You'll get 3 syringes. And these are called vanishing point syringes, and you're going to see why they're called vanishing points. Has anybody done naloxone training here? One? Okay, so this is new for folks. There's a great little cheater sheet in here. We'll talk about the steps, and it helps prompt people if you need to know. There's gloves, alcohol swabs, and then a pocket mask to help provide with breathing. So care and storage for your naloxone kit. So naloxone doesn't like light. That's why it's in an amber-colored pill bottle and amber-colored ampules, because we don't want it exposed to light. When it gets exposed to light, it starts to lose its effectiveness. It does not like heat either, so if you're storing this in your car during summer months, probably not a good idea. Spikes up to 40 degrees for a sustained period of 24 hours, you'll want to replace your naloxone. And all kits, Health Canada takes very good care of us and puts expiries on everything. However, if all you have is an expired kit, we encourage you to use it. Any naloxone kit that you have in front of you is the one you want to be using. So if you know that it's been exposed to heat, still use it. It just means it's a little less effective. If you know it's been exposed to heat and you have time to go get a new one by going to a pharmacy and asking for the naloxone to be exchanged or to get a new kit, we encourage you to do that. I'll just pause here and see if there's any thoughts, head scratches, questions, curiosities. Yeah.
What do you do with expired naloxone?
Yeah, naloxone, yeah. So you can take it to a pharmacy. On the Toward the Heart website, everyone's going to get one of these brochures. There, it says towardtheheart.com. There is a site finder. And so it's in the top right-hand corner, it says site finder. If you click on that, a map will come up, and you can say where you're located, anywhere in the province. So you would just type in Victoria. There's a drop-down menu that says, what am I looking for? An OPS, safer sex, safer drug supplies, naloxone in pharmacies, or naloxone in community agencies. And you pick what you want, and a map will pop up, and then it'll give you an address of where you can go. So those are all the publicly registered sites. Yeah. Yes?
We have heard that recently there's now sprays available for naloxone as well. Is that part of what's available for the
Yes. So is there actually naloxone spray, and it's nasal spray? And there is. However, it's not a part of the BC CDC program, but you can access it, and you can get it without a prescription, and you would go to a pharmacy and you would request it. And it comes in a box of 2 sprays when you buy it from a pharmacy. So it doesn't come with the gloves or the mask, so we always encourage people to pair the 2 together. So if you want the nasal spray, absolutely, you can go buy it. Did I say how much it was? 2 sprays are about $120, where an ampule is about $1.50. Yeah.
Is that just because it's harder to make something
Well, I have a story. I could tell the story. One, we don't have enough competition, so we need another nasal spray of some sort, which will help reduce the price. So the company that manufactures the nasal spray is an American company, and so it got introduced. Health Canada had to approve them to distribute throughout Canada, and when they did that, our take-home naloxone program was already well established. So in Ontario, they have a take-home naloxone program, and they use nasal spray. So we actually, because people have lots of questions about what's the difference between nasal and injectable, we have a one-pager on this that just highlights what the difference is. So I'm just going to talk a bit about the difference before I do. Is there anything you want to be adding?
I was just going to say, correct me if I'm wrong, Tracy, the First Nation Health Authority does provide the nasal sprays for free.
Oh, yeah. What Candace is saying is the First Nations Health Authority provides the nasal spray at no cost for people that might have a benefit card through the federal government. So they could go to a pharmacy and request that. Now, because it is so expensive, if you have that status card and you go to present, you might not be able to get the naloxone in that moment, so it's always good to call ahead and they can order in. So pharmacies don't like having medications that aren't going to be used on shelves, so it usually takes about 24 hours. The interesting thing about the nasal spray, if you get it covered through the federal government, it comes in a container a bit wider than this with everything included. So that's one way of getting it. And then just the difference really is injectable is much more powerful than, the nasal is much more powerful. It's equivalent to about 5 doses of an injectable. So we're looking at 1.4 milligrams to 4 milligrams is the difference.
Is naloxone dangerous if it's administered when it's not needed?
Great question. Yeah, can I just finish talking about this and I'll talk about that? Yeah. So for people that might have a nasal spray, if anybody has like congestion or deviated septum, or maybe even snort substances, those nasal cavities could be blocked and it might actually have no effect. So it's always good to companion the two together, because then you can have the injectable if you do need it. And when you've done 1 dose of nasal spray and you do the 2nd dose of nasal spray, your sinus cavities have been saturated. A 3rd dose isn't going to make a difference, where a 3rd dose of the naloxone here could possibly make a difference. Okay, so back to your question. Remind me again. It was a good one.
Is naloxone dangerous if administered when it's not needed?
Right. It is not dangerous. So if you're in doubt, we encourage people to administer it. If someone is unresponsive and you're not sure why, it's good to administer, because we'll talk a little bit about what happens. It gets absorbed into the body. It won't do any damage to a heart or the brain. Its only one purpose is to reverse an opioid overdose. So yes, very safe. If someone is actually expecting, you could administer naloxone. You could administer it to a youth or a child if you needed to.
Or animal?
Yes, it's effective for dogs, animals. Yeah. Oh gosh, naloxone. Hey, nurse. Oh,
I have no idea. It's naloxone, I don't know.
yeah.
I don't know what it is, do you? Like, it's naloxone.
Yeah.
I don't know. I don't know the compound of it. You have the slide of that opioid.
Yeah, I do.
Maybe that will help a little bit.
It's just a powerful, response, and obviously doesn't have huge side effects if you're not in that condition, so it's a bit of a wonder drug.
Yeah, true,
Yeah.
very true.
Yeah, and it's a great thing to have on hand when you need it, but it is not going to change our toxic drug supply or change, it's not preventative. It's a response to save someone. Yeah, so let's see if I can get this over a bit more. So yeah, its only one function is to reverse an opioid overdose. So when we think about the unregulated supply, we know that it can be contaminated with other things. So unlike alcohol, we know what we're going to get when we go to a liquor store. It's written on the bottle, what the proof is. It's been tested, we know. And when something is not right and we find out, there's a recall. That doesn't happen in the unregulated supply. So we've seen a huge introduction of fentanyl into the supply back when the public health emergency, even before it was declared. And fentanyl is a very effective medication. They use it at end of life for pain. They use it during childbirth. There's fentanyl patches people wear. So it's an effective medication, and it's found its way into our supply. So when there's a place where you can actually get your substances tested, and they produce a weekly report. If you go to Substance, it's called Substance. There's a brick and mortar store right on Cook Street, and you can look once a week at what the reports have to say. So we do see these opioids showing up sometimes in stimulants. So when people might be getting cocaine, it possibly could be in there too. All right, so when no opioid's present, it has no effect. So if you're unsure, it's quick. The onset's within 2 to 5 minutes. And it can last up to 30 to 120 minutes. And then what happens is that bind loosens, and the opioid binds are stronger, so those opioids that have been displaced can reset, and you can actually experience a secondary overdose. That's why it's important to be calling an ambulance, or if someone is wanting to leave, you need to let them know that they have naloxone on board to be with someone safe. Mm-hmm. You could, yeah. You could. So how does this work? So this hopefully addresses some of the questions. So what happens is when you've ingested an opioid, it actually attaches to the receptors in the brain. And when you've overwhelmed those receptors, what it starts to do is decrease the respiratory system. So it tells your body to slow down your breathing, so that heart is still going to be beating. However, you're not going to be getting enough oxygen. This is why our overdose prevention services are so effective, is because they're witnessing what's happening in the moment. The challenge is when people use alone and we don't have enough time to respond, because then we found someone maybe too late. So those opioids will eventually tell the whole body to just stop breathing, which will then lead to a change in the heart. And so then when you introduce naloxone to the body, it goes to those receptors where those opioids were, and it chucks them out, and it stands guard. But of course, it's only going to be there for that 90 to 120 minutes, and then it's going to loosen, and those opioids could actually reset themselves. So if anybody is in a dependent way around using opioids, and you introduce naloxone, they're going to feel ill. It's going to push them into withdrawal. And so if they rouse after you've given them naloxone, a couple things might happen. They might want to go use again because they want to get rid of that feeling of that withdrawal. And if you introduce more opioids, when that naloxone releases, you're going to get a double whammy of those opioids. So that's why it's really important to just tell people you've got naloxone. That feeling of sickness will soon dissipate because that naloxone is going to slowly release, and try and encourage them not to go use again, because we don't want to double that dose. Candace, is there anything you want to add?
I just wanted to follow up on your question about if you can give naloxone 120 minutes after you gave it. You can actually give naloxone 3 minutes after you've given it, and you can keep giving it until that person's responding, just to be clear, because again, Tracy's mentioned it's safe. So we kind of have a 3-minute window. They're still not responding. We can give them an injection of that.
Yeah. So we'll talk a bit more about, like, there's 3 doses of naloxone. You don't necessarily want to be moving to another kit, but when you've called 911 in Victoria, it would take about 12 minutes for an ambulance to get here. So your response, hopefully you're not even on your last dose of naloxone, that an ambulance would be here and be able to provide some support. Okay, so I'm just going to run through the steps, and actually what I wouldn't mind doing is giving these out so people can follow along. Candace, would you mind being my Vanna White? And I'm just hoping that people will just pull out the brochure. There's going to be other supplies in here that we'll use later to practice, but I just want to focus on this brochure. So this is very handy. You can take this with you. You can put it in your naloxone kit when you're done tonight. And it has an opioid event, and it has a stimulant event, so you can see the difference. But when we're looking at signs of opioid poisoning, we're looking for these kind of clustering of signs. So when we think about that opioid telling our respiratory system to slow down, what might we notice? If people aren't getting enough oxygen, what do we notice? Yeah, we begin to turn blue, our lips turn blue, nail beds turn blue. A person of color might turn ash. Yeah. What else might you notice? And it's okay to say what you see. I won't know that. Yeah, so people might feel cold and clammy to the touch. And so when I think about that, you can combine your responses. Barb, are you okay if I touch you? Yeah. So if I'm concerned about Barb, and I'm like, Barb, are you okay? I'm always going to say what I'm going to do before I do it, because that is a good way to reduce trauma. I'm just going to touch you, Barb. I just want to make sure you're okay. And she's not responding. I can then feel if she's cold and clammy. So I'm combining kind of the steps together. So we might hear snoring or gurgling sounds. That doesn't mean someone's sleeping it off. And this is where my concern goes for youth. Or maybe anyone, but my mind drifts to youth. So if people have been drinking alcohol and they lower their inhibitions, and then they might take a pill that's been provided, and let's say there's an opioid in that pill, that alcohol is going to make that opioid act even stronger. And if someone's like, oh, I'm not feeling well, I'm just going to sleep it off, and they're like, oh yeah, Tracy's just snoring over there, having a good rest, it might be because I'm not breathing well enough, so I want to go make sure and rouse them. So we're looking for this clustering of signs. And then to respond, yes.
This might be a question, but it mentions contracted pupils. Is that just like as a pupil response, or would like if you were trying to think, would they not respond at all? Like, that usually they contract and dilate.
Yeah, I think my hunch would be they'll be small to begin with. They might get a wee bit smaller, but they won't be dilated. Yeah. And that might be hard to notice because often people's eyes are closed and they're on a nod. So you don't have to go lift the eye, if it's something you notice. And then your response is save me. 2 words, each of those letters and those words stand for a step in the response. So S is stimulate, and you want to rouse them. So just as I mentioned to intervene with Barb, thanks Barb, I'm going to use her name if I know it. I'm going to say, are you okay? And see if she rouses just with my voice. I don't have to yell. I can talk loudly, and then I'm just going to say what I'm going to do. So if I've roused Barb, I've tried to give her a shake, and then I'm going to say, Barb, I'm going to apply some pressure on your shoulder, and it's going to hurt. So then I'm going for a pain stimulus. So I'm digging my finger into the collarbone or pressing the nail bed. And if anybody's done naloxone training before, we used to talk about a sternum rub. So we've moved away from that. This tends to create too much pain, and often in the heat of the moment, we might get a little too excited and we're pushing too hard. I'm pushing too hard. I don't know why I have to do that, but I do. And so no response, that's where I want to call 911. And I phone 911, I let them know that I'm responding, let them know where we are. If there's someone else, you want to partner with that person so they can either meet the ambulance to bring them in, or they can be doing the phone call while you're preparing the naloxone. So if you've got a partner, better to do it together. If they're new to this and you've been trained, you be the boss and you tell them, I want you to call 911 that I'm responding to someone at this location, and I want you to go meet the ambulance and bring them here. And then A is airway. That's where you want to actually check the airway to see if anything's in their mouth. There's gloves in the kit, so you can put the gloves on. And you want to see if maybe they've been chewing on some gum. If they've actually injected, they might have the cap of the needle in their mouth. So you just want to finger sweep that out and make sure it's clear. And then you'll see them doing a head tilt here. This is where you really want to get a good extension on the neck so you can provide rescue breaths. So you could visualize, if the person's lying on the ground, a pencil in their nose, and you want to make sure that pencil is sticking straight up into the sky. So you want to visualize, not put a pencil in a nose. You're thinking about that. And then you want to provide ventilation. So this is where the pocket mask comes in really handy. And because you're responding in an emergency, this is something we probably don't do frequently. So your heart might be racing, you might be feeling anxious. When you get this mask out, it's a good time to just kind of think about your own response and take a deep breath. And so this pocket mask has a bit in the mouth, a pokey-outy bit, that's a medical term, that actually goes into the person's mouth. You know you've got it the right way, because if you turn it the wrong way, all the directions are backwards, and I can't read it. And this provides you the steps. So if you're unsure about how to use this, it just goes over the mouth, it gives you the directions, you pinch the nose, you've got that head tilted, you give a breath. And you give a breath every 5 seconds. And you want enough oxygen, breath, to raise that chest, not so much to distend the stomach. Because if you keep pushing air too far in, that's where someone's going to be sick. The great thing about this is a one-way valve. So if someone is sick, nothing's coming through here. If they are sick, then you would just roll them onto their side, use your gloves to sweep the mouth, and then go back to rescue breathing. So if you provide ventilations about 20 to 30 times, then you want to evaluate, has my rescue breath actually made a difference? And sometimes, just enough to oxygenate the blood, that person might rouse. And then you would just roll them into the recovery position and let them know that help's on their way. If you evaluate and there's been no change, that's where you want to move to the me and the M to administer the medication. So this is where you'd either do the nasal spray or the injection. And so you would draw up your medication and you administer the dose. The great thing about these needles is they'll go through clothes, so you don't have to expose skin. So the two places you can inject are your upper thigh or upper arm. Yeah.
So you typically only administer naloxone if someone's unresponsive?
That's right, yes. So the question was, I don't know if people need to hear that, would you only administer if somebody was unresponsive? And you would. If someone's being able to respond, they probably don't want naloxone. And especially if someone has been living rough and pursuing what they need to get their needs met, they've probably worked really hard and don't want that interrupted for them. So if they're unresponsive, we don't want to that's when we want to administer the medication. So again, upper thigh or arm. I'm not a nurse. I'm going for the thigh. I want more muscle mass. Candace is a nurse. She might be a little more finessed and go for the arm. Anything you want to say?
I've taught this course in a different sort of way, and I find a really common question people have is where first. It doesn't matter. So some people might hear, oh, I got to go to this side now, I got to go to that thigh. It's okay, pick your spot, just as long as it's a thigh or it's just the meaty part of your body that we're talking about.
Yeah, and we used to train that you could inject into the backside, but that's no longer a thing. We want to avoid doing that. There's a nerve that goes down, and we don't want to poke it. And usually if someone's lying on the ground, you're not going to have access to their backside anyhow. Yeah, and so when you administer that medication, you want to wait 3 minutes before you administer that other dose if they're still unresponsive, but you're not waiting. You're going to continue to provide those rescue breaths. And so this is where, if you're alone, you can ask that 911 operator, can you tell me when 3 minutes is up? So that you can administer your next dose. Or you ask your partner, can you please tell me when 3 minutes is up? And if you're on your own and you've got your kit and you start to provide those rescue breaths, you want to get your kit out, provide a breath. Unzip the kit, provide a breath. Dump the kit, provide a breath. Grab your naloxone and breath almost in between every step. So by the time you're done and you're ready, you can administer that naloxone. And then you have 3 doses, yes.
Oh, sorry. I was going to say regarding the stimulant, I've done my first aid. I'm talking about the first step, these stimulate. I've done first aid and CPR, and I was told that actually that when you approach somebody who is you think is unresponsive, you actually just first of all, just use your feet when you approach them as opposed to just coming over them in case, you know, they turn around and they're not actually unresponsive and they whack you one.
Yeah, yeah, and so I'd say context is really important. And if you notice someone in the community that you're concerned about, I stop and I observe. So I take a look. How are these breaths going? Do I notice pink lips or blue lips? Are they snoring or gurgling? And I'll observe. And if they look okay, that they're breathing, then I'll carry on. If I'm concerned, then I'll say, hey, are you okay? And 9 out of 10 times, I get a thumbs up or, yeah, fine. People appreciate being checked in on. And if there's a buddy beside them that's alert, is your friend okay? And they can check on them. I would say everything you're doing again as you're approaching. I would avoid any sort of kicking of the foot because that tends to be a police technique, and I don't want to be identified as a cop.
Yeah.
And people that are on the living rough on the streets have all their valuables with them, and they're going to want to protect those. So we just want to say what we're doing as we do it. And just keep talking as you approach closer and closer, and just, hey, are you okay? So I might rub the thigh or the bottom of the leg. Yeah,
Okay, good. Thank you.
you're welcome. No, I thought there was a hand up here. Yes.
If they're breathing, are they okay? I mean,
Good question. They need to be breathing anywhere from 11 to 12 breaths a minute to be okay. Anything 10 and under, we're concerned. So I think people sometimes think, oh, they're breathing, I don't need to administer naloxone. They're just not getting enough of an expansion in their lungs, they're not getting enough oxygen.
okay, so they still might need naloxone.
Yeah, and they could be breathing and still unresponsive. Yeah. Nurse Candace, anything you want to add to that?
Yeah, again, this is a common confusion when I teach this more extensive overdose response course is the people that are still breathing need the naloxone. The people that aren't breathing anymore, they're dead and they need CPR. So we're still assuming there's a person they're still breathing, but just not enough. And our biggest concern is that if they're not breathing enough, like we're all breathing about every 5, 6 seconds right now. We're all taking a breath like that many times. When you don't do that enough, you're not getting enough oxygen to your brain and you're gonna have brain death. So that's like our biggest concern when we see these people is they're not getting enough breaths to give their brain enough oxygen, but they're still breathing, if that makes sense. Just not enough, yeah. So you give naloxone. Yeah, if they're still breathing but not enough, you give them naloxone. If they're still breathing and you don't know if it's enough, you can give them naloxone.
Yeah.
If there's no breathing, they're dead, you can still give them naloxone,
yes.
with CPR, you know. Yeah. What were you gonna say, Tracy?
I think you just answered my question, which is that if you do have to administer CPR and they do start breathing again, you still probably want to administer the naloxone at that point, right?
Yeah, for sure. And we're not here you are not experts. Even if you were an expert, lots of times we don't even know why that person isn't breathing. Like we've had, people that are having, like we don't even know, is it the drug overdose? Or maybe they've fallen and hit their head. We actually don't know, and it's not our
Yeah, you can
capability
use
to even
context
know.
to try
So
and
it is, again, like
discern,
you've said, it is
but-
okay to give the naloxone, even if you're not sure why. It's just a matter of if they seem the signs that Tracy's explaining and they're
Okay.
not breathing enough.
Cool, thanks.
Yeah.
Yeah.
If somebody says, no, I don't want anything, that's a sign that they're feeling okay, so don't do anything.
Yeah. So if someone is intentional with their commands to me, I'm not going to administer naloxone. Whether that's actually, they give me this, I'm fine. If they can intentionally move and give me a thumbs up, I'm not going to administer naloxone. Yeah. I just wanted to talk a little bit about the unregulated supply. So we're seeing benzodiazepines show up, and it creates a very similar presentation as an opioid, but a benzodiazepine is not an opioid. so naloxone's not going to work. This is where things get a little more nuanced. And this never, when I first started, this was never a conversation because it wasn't an issue, and now it's become a challenge. So people will be unresponsive much longer, but they'll be breathing when you've administered that naloxone. That's what's strange about this. So you might not be rousing someone, but their breath might come back. And so you begin to see the lips turn pink, become a little more rosy in the cheeks. And so when you notice that, and they're getting good breaths, you don't have to continue to administer naloxone. But hopefully, again, you're going to have the ambulance and the paramedic there before you have to be making these decisions. Okay. So, of course, aftercare, when the person rouses, you want to let them know what's happened so you can tell them that they have naloxone on board. Sometimes people, if they're not someone you know, they might want to bolt. They get up, they don't want to deal with the ambulance, they might not want to go to the emerge. Any idea why that might be? Money, yeah. So sometimes there's a cost to taking that ambulance that's not covered. Sure, right. So stigma, worried about stigma. Other people might be really embarrassed and don't want this on their health record. So it's just important if they want to get up and they want to leave, it's just your job to inform them what's happened, that they've gotten a naloxone on board, and to go be somewhere safe. If you have another kit with you, you can hand them a kit. Not that they're going to necessarily administer to themselves, but if they're with someone else, they'll be able to do that for them. Yeah, so not your job to hold them, pin them down, and say you need to wait. If they decide to go, that's their choice. Yes, it could be. It could be dangerous to be holding someone against their will, yes. All right, so we're going to just talk a little bit about resources. So I mentioned Toward the Heart. So that's where you can find additional kits. So if you go home and you're talking to someone and they're like, I want a kit. How do I get a kit? So you can tell them they can go to the site finder, and then on your kit there's naloxone training. So people can do this online. They just won't get the practice that you'll get today. But they can print off that certificate at the end and go into a pharmacy and request a kit if they do the online training. And then I've brought some other resources. So we have the service link line. So if people are curious about, I think I want to do something different and maybe start on some opioid agonist treatment, they can phone and find out where that's being offered. As a part of my job, when I work with our medical health officers, we sometimes have to issue, and you may have seen these, toxic drug alerts. Have folks seen those or heard about those? You can sign up to get them actually on your phone. So if you text to this number, then if we're issuing an advisory, it will actually come to your phone, and it will link you to other resources. So if you want those, you can have those. And then we have a resource card here that has a service link number on it. And then somebody mentioned decrim, and I'd say this is probably our first kick at the can for decriminalization, which happened in 2017. And this is the Good Samaritan Drug Overdose Act. So this is to protect people when they're responding to someone who's experiencing a toxic drug event. So there's some things that the law will provide protection for, and some things the law won't. We know that when police show up, they come with an investigative cap, literally. And if they see something that's causing them concern, like lots of substances or lots of money, that they could do an investigation. If anybody has a warrant out for their arrest, it won't protect them. But the idea is that if you're responding and supporting someone, that you will not be arrested or the person receiving the response. So you can take one of these out as well and put it in your kit. And for folks that might be Using alone, there's the Lifeguard app, so you can download that app on your phone. Oh, thanks, Candace. And you would actually start a timer when you go to use. And when that timer goes off and you don't stop it, it will actually send an ambulance to your location. So you populate it with some information, and then it'll send an ambulance. Yeah, and then that's the drug checking service, substance. Yes.
Can somebody sue you, you know, for being an addict if you're giving them naloxone and they didn't want you, but they weren't in a position to respond back? You gave it to them, could they turn around and sue you?
Yeah, so the question is if you will be sued if you administer naloxone and they rouse and didn't want that. They might be cranky, but they can't sue you. You're protected under the Good Samaritan Act, the other Good Samaritan Act. Yeah. Yeah, and I'll just say another thing. So if people are using substances in a dependent way and you introduce naloxone, and I said it kind of pushes them into withdrawal, people might be cranky when they come around. Some folks might be. I know there's often lots of like, people are violent when they get roused. I think that's a little overstated, but we always want to be mindful of how we're intervening and supporting someone, especially if we don't know them. But they might be cranky. Typically, people will not be violent. A colleague of mine would even say, I'm undoing the naloxone kit. So they hear a zipper, so people know that they're not being taken advantage of, or someone's going into their backpack. Yeah. There was a hand up here. Yes.
How long does it take after a person ingest drugs for them to pass out and stop breathing?
Yeah, I think that varies depending on the potency of the substance. So sometimes we've been seeing people respond right away, and other people, 30 minutes? Yeah?
Yeah, you'll see people smoke fentanyl or smoke crack, and they'll go down instantly. So it could be really quickly or have a slower effect, for sure. It varies, but I'd say quicker, more often quicker than later.
Can you fill in some knowledge gaps for me about the drugs that are listed? There's some in here, and the
Diazepine?
I saw that. But others that I've heard are methamphetamines and crystal meth. I don't know enough about these things. You know, it's drugs. You're overdosing on a drug.
Mm-hmm.
What do we need to know about these different things?
Yeah, so there are other substances, different categories. So crystal meth and what was the other one you mentioned? Methamphetamines are not opioids. So naloxone is not going to work on them. And what I would say is you don't have to know what all these substances are. You just know that you've got naloxone and you can respond if someone's unresponsive. Because we know that an unregulated supply, sometimes those opioids creep into those other streams of substances, even though if I'm using cocaine, that's going to increase my heart. It's more of a stimulant. I'm not looking for a down, but sometimes an opioid's in there. Yeah. Oh.
Do you mind touching on how people become sort of like drug addicts? Because unfortunately there's a sort of stigma attached to people who become drug addicts, but they don't start out to become a drug addict. It's just maybe pain medication that they have got used to from being in hospital and can't get off the medication. And so, I've spoken to a few people who just think, these are people who are, like the scum of the earth and don't need that time. And it's such a shame because you realize, no, they're folks like you and me who've just hit a bad part in their life, and that of no fault of their own, they suddenly become addicted.
Mm-hmm. Yeah. Anything you want to share? I can say a lot.
Yeah, so I could say a lot. This is like, one thing I would say is, have you heard of Gabor Mate? Gabor, and last name's Mate. He's a doctor and he works on the downtown east side of Vancouver, which, as you probably know, East Hastings is the cream of the crop of this world, and he works with them and has a ton of videos on addiction, and they're really fascinating. And I think he comes, some people have so if you ever want to Google someone to listen to about addiction, he's got a lot to say about it that I find quite fascinating.
There's also lots of information out there about childhood adverse experiences. So people that have experienced trauma, that seems to be a very common theme. And often Candace and I do our work in partnership with people with lived and living experience. And someone I work with closely, Beth, who is a peer with Island Health, she talks about her own story and talks about the impact of some significant losses in her life. So some people can, like in the States, we hear so much about Purdue Pharma and Oxy and how this was non-habit forming. And so people did get dependent on it. And I think it's really about connection and having meaning. And when people don't have that opportunity to develop those meaningful relationships or feel safe or secure, they're addressing emotional pain, maybe not physical pain.
I find just from anecdotal and personal experience of people that I've talked to, a lot of people who find themselves in unfortunate situations with drugs have ongoing mental health issues. And that, I don't say that to stigmatize, it's just an unfortunate reality sometimes that a lot of people with ongoing mental health issues aren't getting the care they need or the resources that they need. And sometimes that's due to living or financial circumstances. And sometimes those mental health issues cause those living and financial circumstances or pile on top. It can be a lot of things, but those can unfortunately sometimes lead people to self-medicate or seek other ways to deal with their conditions, and that can lead to certain, unfortunate circumstances when piled on top of other things as well. So, but that's just from people I've talked to. I wouldn't say that that's everyone, obviously.
Yeah. And I think everyone has a story, and I think that's why we have to be compassionate and understanding, rather than having a knee-jerk reaction. So we're past our break time, so we're going to have a break. But before you go, there's other resources up here on language and why that matters. So that's helpful. And then I brought, these are decks of cards that come in decks. There's, I think, about 5 decks. These were really created as a part of our harm reduction policy for Island Health, but it's to spark conversation. And each of these cards have a question. How do substances enhance experiences or coping? Well, the other end of the spectrum. And they're themed out into harm reduction, trauma and violence-informed care, and cultural humility for cultural safety. We paid people with lived experience to do the artwork. I didn't dream up the cultural humility questions. We went to elders and Indigenous leaders and communities to get questions. So these aren't ones I formed. These came from people who are the experts. So you're welcome to those.
And then I just have the services that we provide at Island Health up here. I can explain, it would take another 20 minutes to go through them, so I won't bother. But if you're welcome to come up here, I can tell you our services that we provide and at least give you a bit of education around if you want to help any people. I do have some pins here. This is the, you might see this, it was Overdose Awareness Day on August 30th, I believe. August 1st, and this is the color
31st.
that we wear for Overdose Awareness Day. Anyways, we can put all these up here. I also have these forms. I think we mentioned I was going to give you some, Barb. It says know how to recognize an opioid overdose. So you're welcome to take any of these with you. And then after, I think we're going to do some poking of oranges, right, Tracy?
That's right. Yeah. So we'll take a break, and you can help yourself, and we'll come back together in about 8 minutes.
for the church. I don't want to.
Right, right. Right. Yeah, 100%. Yeah, there's a good course at Camosun, 9-month course, addiction and mental health. A lot of people that we work with take. Yeah. Let me know if you have any questions on any of this stuff. Or just grab it all, I love it.
I'm just taking everything.
Yeah, we'll read it our leisure.
Yes, it's such good entertainment. Okay. No. No. No.
It doesn't do anything except for disrupt the opioid response. So if you were to inject it into somebody who's not taking any drugs, it just wouldn't do anything. It might,
And if
make them feel
you
less
ever
sick.
did see anyone that was pregnant and looked, I would just call an ambulance for sure on that one. And we can give it, yeah. But yeah, we're out, yeah, it's hard to hear sometimes.
I love the idea of these cards, by the way.
Yeah, like, I don't know if you ever have any people outside of the church. This is both the encampment, this is, any homeless folk that you see outside the church. We do have,
the hinge.
program in
These are the
Island
clips
Health
right
at
here.
our site.
I know,
And
I
they're
did the same
encampment
thing.
team, they have a nurse and a social worker. And you can call that number on the back, and you can actually, I can give these to Barb as well.
Okay, she's with our congregation.
Okay, yeah, yeah. So this is a number you can call, and you can say, hey, we've got some homeless people that have been sitting here for days, can you please come and check on them? And our team will come out, a nurse, a social worker, and support worker.
We've got police and stuff.
Right. This might be a good start, because we know a lot of the people out there.
Yeah.
Yeah. And the police is just, it doesn't give you the kind of service that it can.
Yes, whatever you can pass on to Barb.
Yeah, I'll give these to Barb. Yeah, and even like if you have people outside your church, there's Victoria's Sobering Assessment Center, you could send people down there. Yeah.
Sometimes we just don't want to be part of a bigger
No.
community.
Yeah, and that's what it is.
Yeah, well, I know, encountered in the graveyard.
Oh, really? Yeah, I'm not 100% sure where the church is, because we thought we were going there tonight. Or, well, I did. It's on 4th Street you're talking about. Or we're here. Oh, is this the same church?
No, that's
St. Luke's.
Okay. Yeah, you can call us.
the church you're thinking of is on First Street.
Yes.
We were going to
Yeah, Barb said to change it to Cedar Hill, yes.
give us a call.
Good. It'd be fun to do it again.
Yes, we go together.
Yeah.
There are people even in our own congregation who are away right now.
Oh, right.
Sorry that they can't be here tonight. So we want to be able to do it again.
Yeah.
Probably,
Yeah.
yeah, you need to go and get yourself a refreshment.
Yeah, thirsty. So we're doing it here. It's fun. And then this. Okay, cool.
40,000. We're good? All right. All right, I'm going to do a quick demo on the naloxone, and then I'll invite 4 people at a time to come up and give a try to revive an orange. Okay. And it's nice to just have 4 at a time because I get a little anxious with needles flying everywhere. So want a bit more of a controlled environment. Yeah, and again, I just want to go back to when you're responding and you're concerned about someone, your heart rate's going to be going. It's going to be a lot of energy and adrenaline pumping through your body. So this is important to take some time to breathe. Especially, that's why I like thinking about that pocket mask breathing. For someone, you got to breathe for yourself, just like that good old airplane spiel that you get. You need to get that oxygen mask on you first before you actually help someone else. But when you open your kit and you go to get prepared, these vanishing points, it says peel here. They're butterflied. Really easy to open, just like cheese string. And so the needle is going to have three parts to it. And so you don't have to be opening this yet. I'll get you to open it here. It's going to have the plunger, the barrel, and the needle. And there's a cover on the needle. These are stiff, so I like to prime it. I always pull it out, and then I push it back a little. I don't push it completely to the end. I leave myself enough room to be able to grip it. And then I will then get my naloxone ready. And these, what you're going to be working with, are water ampules. There is no naloxone in them. And so they are glass, they're not amber colored, and this is intentional because we don't want to mix up naloxone and water and give somebody a water ampule. So they are going to be clear in color, and Candace has got some other ones there that she can take around. And the other difference with these is the ones Candace is going to give you, there's kind of 2 different brands of naloxone that are out there. Sandoz and Intelligent or something. And so they have their glasses scored. So the one Candace is showing you has 2 rings around it. Some of the other naloxone will have a light silver dot, and it just means the glass is scored to make it easier to open. So if you have a light silver dot and you don't see the rings, you want to make sure that dot's facing away from you. It'll make it easier to snap open. So if you go to snap it open, you're like, why is this not opening? Just, oh, right, the dot. Just find the dot. So before you go to open it, what's going to happen is if you've been carrying your naloxone around in a backpack or on your hip, it's going to be bebopping around, and some of that naloxone is going to get stuck up in, they call it the neck. So you want to push that naloxone into the bottom of the ampule. And the way you do it is you just give it a little swirl, a little romance. It's nice and gentle. And it pushes the naloxone down. So I'm just going to show folks. See how it's not even half full? And so if I give it a little swirl, see how it just fills right up? So it's not expanding the naloxone, it's just pushing centrifugal force. And then you find that, want me to take that? Thank you. I'll come get it in a minute. So when you find that dot, you want it to face away from you, and then I grip with my thumb here and my thumb on top. These plastic things, they're called ampule breakers. They're to protect your fingers. So if anybody here has done nursing before or veterinarian, sometimes you won't see those ampule breakers on. Sometimes people use alcohol swabs to open them, but this is to protect your fingers. We're working with glass, it's going to be sharp. And then you want to flick away from you because sometimes there's the little glass shards and you just want them to go that way instead of towards you. So you flick your away, but you turn your, and you want to own it like a boss. Just snap it off. And then my magic trick, ta-da. Thank you, science. It does not come out. And then my public service announcement. If you ever find a needle, do not recap it. That's where needle stick injuries happen. So when you're ready to drop the naloxone, you take your cap off. You never want to stick it back in because that's where you're going to get poked. And then you take your needle and you put it into your naloxone ampule, and I try and get the needle right to the bottom. And when you get nurses like Candace, they have fancy ways of drawing this up. They turn it upside down. They do all sorts of things. If you need the surface, you can leave it on there and use 2 hands. I try and grip because sometimes if you're outside, you won't have a place to set it down. And then I use my index finger, is that right? Yeah. On the tab, and then I grab the plunger and I pull. This is another great place to focus on your breathing, because if you're in a panic, you're going to pull really hard. I was a prairie girl, and I learned how to siphon gas. It will do the same thing. So if you stop pulling, the naloxone will continue to come up. And when someone hear that hiss, that bubbles? So it just means you got all your naloxone in there, it's empty. And you want to turn your needle to the sky because you're going to have a little bit of air in there, and you take your plunger and you just push. And you want to make sure your needle's up, because if you push down, it's all going to come out. So even if you have a wee bit of air in there, that's fine. It's going to just bruise or poke a little harder going in. This isn't, if you get air into a muscle, it's not going to create some sort of embolism for somebody. And then you want to hold it at a 90-degree angle. And it goes into the, where did we say these go? Yeah, everyone's pointing, good. Thigh or upper arm. And then I put it right to the bottom. Keep your orange on the table, and then push. And then a little extra oomph on the end. And the needle will retract into the barrel. It's not in the orange. Yeah, so it's no needle stick injury. And so if you've used your kit, you can put it just right back in the kit, zip it up, and go take it in and say, the needles are retracted and in the kit.
I was going to ask how you dispose of the sharps, but that pretty neatly figures it out.
Yeah. But we have a sharps container which we can use. And then you would go back to providing rescue breaths and then administer again in 3 minutes. But we want to give everyone an opportunity to try. Who would like to come forward? Okay, I need 4 people. Got 2 here, 2 more, 1.